Thank you very much, Mr. Kibiki, for those words of wisdom. As we start our session, I will take you through the first part and then I will hand over to my able co-moderator and the main lead for the session this morning. As Mr. Kibiki has already mentioned, we currently implement two projects that are funded by USAID Tanzania. We implement Afya Yangu South, which is a sister project to Afya Yangu North that was presenting in this room earlier this morning. Ours is in the southern regions of Tanzania, and we are in Iringa, Mtwara, Njombe, Morogoro, Ruvuma, and Lindi. For this project, we support health facilities and government of Tanzania to deliver quality HIV and TB services in the regions that we are. And these are coupled with integrated HIV family planning services and cervical cancer screening. We are currently in over 1,000 facilities. I'm waiting for the slides, please. Next, please. As we're getting to the slides, again, these are the services that we are doing. The first result is improved access to quality client-centered HIV and TB services. Result 2, improved ability of individuals to practice positive health-seeking behavior. And result 3, enhanced enabling environment for the quality HIV and TB service provision. Before I continue, next slide please, I want to recognize and honor the fact that in implementing Afya Yangu project, Deloitte is working with MDH and TMAC, who are present in this room. As I've alluded earlier, we're supporting 1,464 facilities. 1,409 of those are offering TB services, and 731 are offering HIV services. This is like our achievements in a nutshell. I'm not going to go through all of those, but as you can see, we have over 2.2 million people reached with HIV testing services. We have about 91% of those with viral load coverage, and we have over 38,000 TB cases that were identified through community and facility health interventions. If you would like more information about this, we have a booth right outside the main conference center. You will be able to be given a lot more detailed information. Next slide, please. The next project that we are implementing is an OVC project called Kizazi Hodari, Brave Generation. And Kizazi Hodari is also implemented in the southern regions of Tanzania. The same Morogoro, Iringa, Njombe, Lindi, Mtwara, and Ruvuma, where Afya Yangu is. But in addition to that, Kizazi Hodari is also implemented in Rukwa, Songea, Pwani, and Mjini Magharibi here in Zanzibar. And Kizazi Hodari, like I said, is also a USAID funded project and is implemented with support from CBOs, CSOs, and FPOs. And the main objective of this project is to support the government of Tanzania in increasing access and use of health and HIV prevention, care and treatment, and protection of children against violence, education and socio-economic services among overseas youth and their caregivers for overall well-being and protection, for their overall well-being and protection, particularly in high HIV burden population. Next slide, please. The objectives, there are three objectives for Kizazi Hodari. That is increased use of OVC platforms for pediatric HIV case finding and linkage to service, increase access to prevention, like I said before, violence prevention, and response for OVC and youth, and then improve socioeconomic and livelihood conditions for the overseas, particularly adolescent girls and young women. Next slide, please. Again, these are our statistics at a glance for Kizazi Odare. To date, we have saved 154,776 out of the 157,291 that were targeted. We are working with community care workers. We are working with independent livelihood providers. We have reached 98% children and adolescents have been retained in care, and 94% of those we serve have viral load suppression. Thank you. Next slide. I think that's last. Now, to take us to the next session, may I introduce Dr. Neema Mlole, who is going to be the moderator for the session. Dr. Neema Mlole is an MD and an MPH and a public health specialist at the President's Office, Regional Administration and Local Government. Dr. Mlole has extensive experience in managing and coordinating HIV interventions at different capacity, including District AIDS Coordinator at Kinondoni District Council in Dar es Salaam. Dr. Mlole focuses on translating national level HIV policies into actionable initiatives and coordinates HIV services across 26 regions. She collaborates with ministerial implementers to mobilize resources and strengthen partners to achieve UNAIDS goals by 2030. Karibu, Dr. Mlole. Let's give her a round of applause. Thank you.
Thank you so much, Scholar. Good morning, everyone. Still morning. Thank you. As we are going to the second part forum, we are called to introduce our presenters so that we can go ahead and discuss what we have in our forum. Our first presenters, I'll start with him. He's a medical doctor with a public health specialist with more than 19 years experience in primary health care. Currently, he serves as Director for Health and Social Welfare and Nutrition Services at the President's Office, Regional Administration and Local Governments. Apart from that, he also has an experience of 7 years as a Regional Health Management and 12 years as a District Medical Officer. He has a deep understanding in healthcare challenges and solution at various levels. He also serves as the Board of Trustees for Muhimbili National Hospital and Medical Store Department. Through his career, he has made a significant contributors for public health in Tanzania. He had made a successful initiative to improve healthcare access, reduce maternal health and child mortality rates, and combat infection disease. He has experience and expertise in leadership and has instruments in advancing public health care in the country. Welcome, Dr. Rashid Faume, the Director from the PRI. As he walks in, take his seat, maybe I introduce another presenters. These presenters is a medical doctor. We have a lot of medical doctors here. A public health specialist with more than 10 years working in public health for both government, ministerial level at Ministry of Health, and the donor-funded projects at the high capacity in Ministry of Health at the Global Fund and the lead. He designed, planned, and property monitoring implementation of the 3 successful Global Fund grants, and at his capacity of MML Director of USAID AFIAM program. He has designed several data engagement initiatives a significantly improved data availability, equality, and use. His current area for management, expertise, and monitoring and evaluation, data management, program design and management, equality of improvement and capacity building. A round of applause as we welcome Dr. Dennis Nzada. Our third presenter, or discussant, is Mr. Kenneth Chima. Kenneth Chima is a social scientist with over 20 years experience in project planning, implementation, monitoring, and evaluation through working with AMRE, CARE Tanzania, FHI 360, Japan, and PACT Tanzania. He has rich experience in implementation of community-based health, social welfare intervention, maternal health, including respectively maternal care, orphan, and vulnerable children. He has also had experience in healthy and social welfare system strengthening adolescent sexual and reproductive health systems. He has also expertise in social behavioral change communication, strategies and campaign, community perspective approaches, and community quality improvement agenda. Another round of applause as we welcome Mr. Kenneth Chima stage. And our last speaker is Ms. Mona Mapunda. Mona is a passionate development practice with over 4 years experience overseeing and leading development projects in multicultural and international contexts. Mona has worked with Canadian Physicians for Relief and AIDS, World Vision, UMAD, and now TCII to bring about design change in communities. Backed up development study degree from Sokoine University in 2009 to 2012, and they have extensive training in UTech and Sukos Business Forum, among others. She also has experience including nutrition capacity building, awareness raising in communities with other populations such as PLHIV, children under the age of 5, the elder and the pregnant women. A round of applause as welcome Ms. Mona to our stage. Welcome, Ms. Mona. Thank you. As we are waiting for Ms. Mona to get her seat, maybe I should also introduce the main part of our forum is based on making an impact that matters through private sector engagement in HIV response at the primary care. To start our discussions, first we start with my director, Dr. Faume, from the PRH. We want to discuss with him through his experience as a regional medical officer, district medical officer, but also currently he serves as a director at PRH, Department of Healthy, Social Welfare and the Nutrition Service. What are enabling environments for engagement of private sectors in primary health care service delivery? Concern how the main part that we need to know the impact of the matter through the private sector engagement in HIV response to primary care. Welcome, Dr. Fox. Another mic, please.
So, good morning, everyone. Yes, thank you very much, Moderator. Private sector engagement or non-sector after engagement is crucial in strengthening the health system, the district health system, but the quality of health services in general. And we all know the role of the government is providing the services. But we went through several phases. From independence to no, we tried to collaborate with the private sector in a pattern that is different from when we banned the private sector. Then during the reforms, we found it importance of engaging the private sector. So despite the fact that the government has that law, but cannot do it alone, we need the private sector to complement the government's initiative. And we have to walk on the top of that aspect. The theme of this year's summit is advocating better practices. Now, better practices also comes with the practices in meaningful partnership. Now, the government has put down several enabling environments to ensure there is fruitful collaborations, mutual support, mutual trust that will be put into practice to provide the required intended targets, objectives, and in turn the quality of the services to the community. Let us please start with the area of coordination. We all know, and for those who have been engaged in the technical working groups at the ministerial level, there is a policy dialogue platforms whereby from the policy formulations, suggestions into the policy or strategy formulation, implementation, monitoring, regulation, levy, resource mobilizations, including also community engagement is discussed. So having this platform for engagement of the public and private in the sector-wide approach is very important. But from my experience, the question moderator was also to link with my experience. The sector-wide approach has been mentioned. Or the intention of sector strategic plan 5 was to summarize sector-wide approach to the regions and to the districts. But we have not made much success in that area, so that's an area that we have to focus on. The public together with the private sector. But coming to the regional level and the districts, their law, as per the regional health management system guidelines and the council system guidelines, it also creates the enabling environment. So at the POL also, we ensure that the subnational levels factor their laws of creating enabling environment in all stages of service delivery. From the planning, we have to plan together, planning, executions, monitoring, evaluation, and learning. The most important thing in that area is openness, transparency, mutual trust, including resources. That's from my experience point of view. But we have been improving that area. Most of the working arrangement has been very transparent and trustful. But coming to the reforms, our reforms, as I say, have introduced or has created an environment, a good environment, conducive environment for private sector investment. Most of the policies act, let's refer to our PPP policy of 2009, the PPP Act of 2010, and this amendment in 2014 and 2023. All these created are the documents that, if properly put into practice, the way we put it into practice is very important, very crucial. Having these documents is not enough. We have all have to have that intention of putting it into practice. But also, the reforms came with ethical financing modalities that also create an environment for private sector to provide the services in a sustainable and productive manner, like prepayment schemes, the NHIF. The NHIF cut across from the public to the private, in order also to create an enabling environment for private healthcare financing. So coming to the health sector strategic plan 5, 2021-2026, it also there are clear statements and objectives that also promote conducive environment for private sector, including how can we work jointly to make sure that we increase access and utilization of health services in all pillars of health system strengthening. We promote the health commodity manufacturing, including medical equipment, medicines, and drugs within the country, and even having procured directly from the industries, whether in the country or outside the country. So those investments are opportunities for for investments from the private sector, and availability of those investment guidelines is also an environment that promotes conducive investment. But you have seen the working arrangement in a PPP service level agreements. There have been agreements in, for example, the government and faith-based organizations. But how we have seen how the government also allocates staff and other resources to the privates. Despite the fact that we are facing both challenges of the resources, but the regional available resources we share. But the most important thing is the quality management systems stipulated under sector strategic plans, like registrations. So apart from all those arrangements, we have to ensure the government that the quality of services, safety is being adhered. And even the implementation of these quality management systems is also collaborating between the public and the government. Lastly, we all know on the context of how the PPP getting involvement between the public and private in the provision of health services towards HIV prevention, care, treatment, and support services. With the example of Deloitte and the support from PEFA, USAID, but working with the TMAC and the MDH. We really think that working arrangement has been very good, and that has been well put in place. With a document like National Multi-Sectoral Strategic Framework, that gets an environment also for working arrangement to make sure that the intended interventions in prevention, care, treatment, and support services are being provided in the manner that has been jointly intended. So to sum up, the PPP is crucial. And you can see the achievements presented here. They really show the real example and the benefit of working together. Having the mutual trust. The umbrellas like Peace and Social Service Commissions, I can see them there, and the BAPATA, the COC of coalitions, we are making a very harmonious environment. The most important thing is, let's be transparent, mutual trust, let's plan together, let's synergize those resources. Thank you very much, Director.
Thank you so much, Dr. Mfaume, as you remind us what the police that rated in your HPC5, which is working currently, but also how the PPP is important to continue the prevention of HIV, but also in working at the primary care. The second panelist, Dr. Dennis, being an M&E specialist, but also you have experience, experts on in managing and several data initiatives, and being also working a part of the government and currently in private sectors. What attachment or private sector in integration of HIV response into private healthcare and the impact we have realized so far?
Thank you, Dr. Neema. So we share also for being able to achieve specifically HIV implementations in private and public partnership. As presented earlier, we support around 752 health facilities, now 6 supported regions, and out of those, 145 private health facilities that constitute around 8,329 people living with HIV. That means if a true private sector was a region, that means it would have been the largest region that we support. In summary, of the 6 regions, the largest one is Iringa with around 65, 486 people living with HIV receiving ART. So this having private sector supporting around 8,359. This is like the whole of Iringa is councils in Joburg. So you can imagine how big private sector is specifically in our system. Apart from having a larger number of people living with HIV receiving services around these areas in private sector, so we have other services that are provided like identifications that include screening for both HIV and TB. We have actual quality of service that is provided in because imagine if all these clients were receiving services public, that means it could be a lot of congestion, and possibly even ability to identify them all would have been achieved by now. But ensuring that these clients are recipients of services that are receiving services, public and private, actually receiving quality services. So in terms of prevention, we all know that our focus currently is to ensure we reach the hard to reach populations, and from the previous surveys have shown that youth and men are the ones that are difficult to reach, and we thought it's important to get private service source that engage in peers that went to hard to reach areas with all this hotspot. And just 1 year we managed to reach around 200,000 men and 200,000 youth. And these populations were provided with preventive educations, given condoms and screening for HIV, some were tested, and some were referred for PrEP and family planning to the nearby facility. So this is something that is commendable, it's very good achievement, specifically on HIV prevention. However, in care, HIV care provisions, we have very various facilities in our supported regions. I mentioned a few like Uganda, I think you are aware of Peramio, San Francisco, where a large number of people go to these facilities for receive services. So we can't anomaly screening, testing, and with this we'll be able to achieve this 27% coverage of people living with HIV in this facility. So having around about 8,000 client on air supported business facilities by modeling and calculations that prevent HIV infection just by this year around 3,372. So this is a bigger number equal to contribution to ensure that new HIV infections are not transmitted this year. Now that in Chile we modeled and found that it's around 900. So this is a very big contribution specifically when we talk on HIV prevention. On HIV quality of service, the main focus is to ensure that the client actually are tested for HIV and get to know their status. And in HIV level, and we have 7 big conventional hospital with HIV testing machines, and out of those 2 are private facility, which is Deloitte and San Francisco. And this, at times, they were the only ones which were running, and by far significantly contributed in the availability of HIV results. But from HIV, we have gene expert machines, around 55 facilities, and all those 16 private facilities. So apart from HIV, we normally now significantly achieve bacterial confirmations for TB cases, around 66%, which is above standard, which is 65%. That's a very big achievement. We've been able to test early diagnosis below 2 months of age for coverage is above 93%, and appreciate HIV suppressions right now is above 98%. So you can see the contribution specifically not only in reaching but ensuring the quality of services is properly provided and appreciated. But identifying client vulnerability is one, but ensuring that they are retained is another thing. So we have several programs that engages schools to ensure that when one is in reality, we have here to ensure that the CHS is client action are followed, ensure that they are there to HIV medications, ensure that HIV is suppressed, quality of life is improved, and transmission is reduced. So these are some of the things that we've been able to appreciate. I know there are challenges, but what we have been able to realize by now is significant enough to say that public-private partnership is actually working, specifically on HIV service provision.
Thank you so much, Dr. Dennis, for well-narrated what we've done currently to support the public and private facility in service delivering for HIV. As we know all that we are currently it's a call for sustainability with HIV program, but apart from what government has been done through preparation of the roadmap for HIV sustainability, but also in the call for all the private sector also to be engaged at that roadmap that's been able also to make a sustainable of this HIV activity that was being expected toward the end of HIV in 2030. Come to this, maybe I call to ask Mona, Miss Mona, through that experience that she has in working in the private sector, but also in supporting all the initiatives that have been laid to the government in HIV. Okay. Maybe should I repeat what we need Ms. Mona to explain for us? What can make the private sector get engaged in supporting health services, particularly in sustainable HIV response? Welcome, Ms. Mona.
Thank you, Moderator. Yes. As we all know that private sector refers to all non-state actors from for-profit to non-for-profit, and can even be individual to organizations, local to international. It covers a wide range of actors, and they're already doing a lot in supporting health services. And according to WHO, over 50% of overall health services providence comes from private sector. But the question is, how can we sustain the support that we already get from the private sector actors? And as we talk about sustainability, we are looking at the ability of the country to have and use the enabling environment, the functional system, and the empowered institution, and which are local, available domestic approaches to be able to sustain the efforts toward ending HIV by 2030 and attain the goals of 3.5 as described by UHC. Now, how are we going to attain that? We know there is already a great motive behind the private sector to support health services because they work with communities. For example, talk of for-profit private sector entities. People are their customers, but coming to charity organization, they also work with people in the community. So it's very crucial for them to have community members who are healthy. So that is the very first motive towards supporting health services as we talk of private sector. But on top of that, to have that sustainable HIV response now, we have to look at a number of things, like we have to build the capacity of community health workers, because if we talk of having empowered locals as people who are in the front in fighting against HIV, they have to be empowered, and you have to get a lot of community health workers from the community towards that. But also we are looking at the engagement of stakeholders. Private sectors have to be engaging from the scratch in the planning process. They have to know what they are to do and what position they should take. So if they will be engaging from the very beginning, they will know their role and what to do, and that will bring about sustainability. But also we talk of using domestic available commodities, and I can even say domestic available human power. We have to strengthen the domestic and use the domestic available innovation and initiatives towards having sustainable HIV response. But also not forgetting what our first speaker highlighted about policies. The policies should be there to govern and to show the private sector what they should do and what should they do in supporting the healthy sector. So having all those in place can help us have sustainable healthy services towards 2030 as described by Universal Health Coverage. Thank you.
Thank you so much, Mona. What I get from the point that the private sector should be involved at the beginning of preparation of sustainability. Maybe I'd go now, we're going to hear also from Mr. Kenneth, engaging of the private sector in sustainable HIV response, particular to OVC and the impact we realized so far. Being as our experience on managing projects, in planning and the programs, what is the insight of these ones? You're welcome, Mr. Kenneth.
Assalamu alaikum. I cannot hear you. So, after the previous presenters have discussed about the policy, the enabling environments, I'll take you to the field and share some of the practical experience from the implementation of the OVC program that is being implemented by Deloitte, Southern projects. Zanzibar Southern Zoning Project, as it is for other projects, it depends on donor funding, implementing it is planned. And despite continued support to ensure effective implementation, however, some of the needs of our targeted beneficiaries are still yet not met. And there are some few issues or factors that are associated with that. One of the major factor is of dependence on donor funding. We have heard that there are some policies, the framework, the guidelines, the tools, but still they're not executed well. The focus is still depending on the donor funding. The second one is the issue of government competing priorities to plan and budget for activities such as the social welfare. We know that is also a challenge. But the third thing that we have heard for several times when we continue with the implementation is that for our case, for instance, we have been told that the OVC funds will keep on diminishing. So that means the implementers of the program, we need to think beyond the donor funding. How can we engage other people to support us to ensure that we provide the services to our beneficiaries according to their needs? Of course, from the design of the program, Zanzibar was designed to ensure it collaborates with other partners, including the private sector, so that it can provide quality, comprehensive, and sustainable services. Kizazi Hodari project developed a private sector engagement strategy that guides the project to work with LPA to map out some of the potential partners and individuals from the regions and from the councils that can be engaged to support and provide the services to our beneficiaries. And the pilot was conducted in Njombe during this financial year 25-24, and the findings indicate that the pilot was very successful, whereby a total of 84 stakeholders were identified and engaged in providing support to our office. I'll quote one of the stakeholders identified, and I thought that I should quote it in Swahili, the way it came out. Because if I try to translate it into English, I may lose its meaning. According that stakeholder, he said, mnakuja basi kwa sababu kuna hawa watu sisi tuna uwezo wa kuwasaidia, kwa sababu wakati mwingine sadaka zetu tunazitoa kwa watu ambao wanazina. That is one of the quotation from one of the stakeholders who was identified in Njombe region. And of course, the objective of the private sector was to ensure we leverage resources so that we can sustain the support for orphans and vulnerable children beyond the lifespan of the project, but as well as ensure we provide comprehensive services, as well as extend the services beyond those beneficiaries who are in the program. As you all know, that projects, they came with a clear defined scope. Sometimes if the requirements are beyond the scope, chances of supporting them becomes difficult. But we also know that there are still majority of these beneficiaries who are not part of the program, who are in need of support. I will cite some of the few examples, vivid examples of the support that was provided by the private sector within the Kizazi Hodari. Some of the projects. One is the agriculture inputs to 6 community microfinance groups in Ruvuma region, whereby seeds, fertilizers, and pesticides was provided to these beneficiaries, and its worth is 73 million shillings. The second example is the vocational skills training and vocational training centers, such as in Tawanya, FUC, Lupaso, VTC, and St. Joseph, VTC, Santa Monica, Mtwara. In cost share, they contributed almost 15 million Tanzanian shillings to support 43 youth to go through their vocational skills. Also here in Zanzibar, in Mjini Magharibi, 78 youth were linked with Cubes Zanzibar. This is a local NGO for the support of the agriculture value chain, while 50 members of the CMG it means the long form of CMG is Community Microfinance Groups, received the initial orientation to benefit from CRDB Banki Imbeju program. Imbeju program is a program that is targeting women that they can access loans and start income-generating activities. So in Njombe, a total of 247 OVC. Out of them, 77 OVC were not in the program, received the support. And when I say received support, these were beyond those that are provided by the healthy facilities and the other clinical partners. And in total, for the pilot that was conducted in Njombe, a total of 54.6 million Tanzanian shillings was collected for support for OVC. Of course, our target was to collect 66 million Tanzanian shillings. And based on the amount that was collected, the following support was provided. That includes scholarship, scholastic materials, scholarships, apprenticeships, placement, wheelchairs, medical costs, health insurance, the use of sanitary pads, foods, clothes, etc., etc. So based on the implementation of the PSC pilot in Njombe, we are planning to scale up to Morogoro, Ruvuma, and Iringa, and the plans are on progress. Conclusion. The engagement of the PS is very critical to leverage resources for supporting vulnerable. Just concluding. Based on the funds that we are receiving from the donor, we should take into account that there is a significant proportion of targeted communities that are still not covered and they are in need of different support. So we need to work in collaboration with the government, specifically through, for instance, in Njombe, we worked through the regional secretariat. We involved the social welfare officers that were in the floor front, and the Deloitte worked as a facilitator of this exercise. Thank you.
Thank you so much, Mr. Kenneth, for well elaborated what the private part that has been done, specifically to the ground where the field, where the peoples are, to the community where we need people to be supported with all the donor funds. Before going back to the audience for the comments and the questions, maybe I should ask one for the government perspective. We heard about the private perspective of the part of the sustainability. What are the government perspective of the part of sustainable of these all the HIV, the good work that has been done with the private sectors in achieving the service delivered for the HIV services?
Thank you very much, moderator. Just to be brief and to inform participant audience who are not aware of the reduction in almost every intervention, reduction in funding, especially donor funded programs. So going towards the 2030, and we have started experiencing reduction in external funding. So in terms of financial sustainability, we have to be aware of that. And the government, we have put in place mechanism for financial sustainability, including joint planning with the private sector. So during joint planning, you will always harmonize resources. Because by experience, sometimes we find the same geographical area, we are competing ourselves on the same intervention. For example, HIV prevention interventions. The same community partners are competing on the same geographical area, while there are a lot of needs in other areas. For some of them, mainly focusing on the urban sector. And when you tell them go to Kigoma, Manyovu, and somewhere, they look into the data. Yes, we go to the areas where the yield maybe will be very much high. But there are areas that are hard to reach as well. Putting local revenues in our plans and the budget is very important. And as a government, we have been dealing with it in multi-sectoral approach, coordinated by targets under the Prime Minister's office. You are all the witnesses in every project. For example, construction projects. The contractors and so forth are directed under the strategic plans to put a certain percentage for HIV interventions. So that's very, very important in financial sustainabilities. The extra facilities are now encouraged also to increase the allocations of funds for not only HIV interventions, but there are unattained gap in achieving the expected target achievements. So our plan towards 2030 is accelerating through integration, through sectoral approach, achieving the problematic achievement that have already been achieved. So I call upon the private sector now. And we're not talking about financial sustainability, or when you're talking about sustainability, people tend to forget other pillars of sustainability. Let's take even the technical aspect of our private sector. Yesterday we had the Minister of Health, a little bit of Tanzania, that under the outreach program of specialized doctors, she called upon private practitioners also to engage in those aspects. So in financial sustainability, even the human resource for us will be important aspect in our daily activity. Political will, Madam Moderator, that is clearly shown by excellent President of the United Republic of Tanzania. But the last issue to my experience, that do not need the directives from the top level, national level governments, the regions themselves, through the regional platform for coordinating the private or the stakeholders, including non-state actors, and even those who are not dealing directly. There are those who are investing in mining and so forth. There is corporate social responsibility fund. How we engage them? So the political will is a very important part of sustainability as well. Problematic achievements, but the financial part, as we are going towards significant reduction in external financing, we have to make sure that we use the local resources, but let's avoid fragmentation, let's avoid verticality on both aspects, the government and the private sector. Let's work together from the planning. Sometimes it happens, the government, when you are planning, we don't call the private sector as potential stakeholders during the pre-planning stage. It happens also to the private sector, especially if there is a long process of assessing funds. By the time the government is engaged, that funding process has already been approved by the funder. So it's just like a dissemination workshop rather than a full planning workshop. Thank you very much.
Thank you so much. Thank you so much, my four speakers, as we narrate how the police needs the law are there. It's a need time now to continue to practice what I need. The political will is in place, but what we need as a PPP, both at our angels and the part of the government, to collaborate and ensure that these HIV services are being delivered at the primary care. So now I welcome for the question, comments, but please heed to the questions. And the base, as they say, the base in our forum is making an impact that matters through private sector engagement in HIV response at the primary care. So we'll be happy if that's a question we base on that line. You're welcome. So can I have the mic? We can start. And if possible, you can mention that you direct that question to each speakers. If that's possible. If not, you can ask. You can take it general. You're welcome.
Thank you so much, Madam Moderator. The question goes to colleague Denise. You mentioned about the private sector as the biggest regions which you support. What kind of incentives do you use or you extend to the private sector?
I think I'll take 3 questions before answer. Okay, that's one.
Thank you very much, Ambrose Wezi, South Africa Solar Mineral Director. My question is around compliance and regulation for the private sector. The challenges we face in health service delivery come from Uganda is even after the government extending a hand to the private sector, then we have a challenge in managing the quality of services and compliance as per the guidelines. While you see assistation rates in the private sector going to 70%, which is way above the because people look at the monetary aspect. So how is the private sector ensuring compliance with regulations so that it can sustain the services? Thank you very much.
Thank you. Can you give me another one and then you take the last one?
Thank you very much. Mr. Pastor, I would like to direct my question to Dr. Following. Recently, we heard that there is a prohibition of public practitioners, providers per se, yes, to practice in private sectors. So, if this comes, how will we sustain this? So let us make sure that we reform things, and we reconcile and resilient. So thank you very much.
Thank you. I'll take the last hand from this side, the right one.
Asante. Good morning, still good morning. My name is Joseph from Pathfinder. I would like to direct my question to Dr. Kaume and to my colleagues from the private sector. So we keep on talking about private sector and the public sector. And when I listen to the way we speak about it, I feel like there is a dichotomy of expectations between the private and the public. The private sector is looking at the government as a source of resources. At the same time, the public sector is looking at the private as a source of resources. And I hear the private sector saying it should be involved. It should be involved. What is the meaning of involvement? What does the private sector need from the government? And what does the government need from the private sector when we talk about sustainability? Thank you.
I say we'll take that for the first round, then we'll go to the second. I think we have to get the right answers. We'll start with Dennis and Dr. Fomi. We have 3 questions.
Thank you very much. Responding to the question, there is no separations between private and public-private in terms of support that we provide. So we as implementing partner, we equally treat public and private to ensure that the kind of service that is provided in private is public as well as available in private. So as what we do in public, we support HRH. I mean, we have station workers in private hospitals. Specifically, and I think those bigger ones have even bigger number of healthcare workers that are private as compared to private. We support training, capacity building. We support them with extended working hours. We control the working extra hours. We support internet with computers or electronic gadgets. But in class, we use it to build some of to see that a private have been built by support by implementing partners. And moving forward in this sustainability, now I get fully planning. And last 2 back years, we had a separate contract to ensure that as private hospitals, they have special needs that are not available in private that we think we can support. So this is what we do, but it's also how we've done. I think we've been able to achieve also how we've been able to achieve. So they are happy, and whenever they have concerns, they normally share with us to address.
Let's get some answers from Dr. Fong.
Let me start with the last question to me from Joseph Kamuhambiro on the way he was following the discussions. The private sector seems as if they have the expectation from the government, and the government has expectation from the private sector. We all know what we need from each other. It's you who have to say what you need from each other. But in my experience, we just need collaboration, working together, mutual trust, planning together, transparency, participation from each other. Sometimes what we need is not much, not money. We can need just your technical support, working together, advising each other. On my side, for example, I've been engaged at sometimes when I was a district medical officer and regional medical officer. Just I was reaching to the research institutions. And what I said, I'm not taking the money from the institution. I said my CHMT has enough capacity for that implementation research. So we just need facilitator from the institutions. I have a little money for, and I will use my venue that is available in my office. And I have little money for tea and refreshment. And I don't need you to pay allowances to my CHMTs. So what we need mainly is what are our priorities? Do we put first money in everything, in every barrier, or there are a lot of issues that we can implement without even treating financing, treating money as a commercial barrier? But what I say, we need a discussion. We need a dialogue. There is a variety of support, variety areas of collaboration. There are many challenges that when sitting together, having a mutual dialogue, we find a way to break into them. They differ from geographical locations, from the nature and the policy of the implementing partner or private sector, but normally from the government side, there's that uniformity. Maybe you can just find the individual specific in the area. So much of what we need will come from the dialogue, from the official structures, or some dialogue are coming from unofficial structures, but then put into our platform for discussion. Like our umbrella organization, as I say, after, for example, Association of Private Health Facility in Tanzania, waste facilities. We have umbrella for coalition of organizations, CSOs. But those are not only structures that can solve each other. So we need to meet each other. We need to engage each other. We need to listen to each other. Sometimes people forget that listening also is very important in meaningful collaboration. So the other issue is the issue of compliance. It's good, my brother from Uganda, you said the issue of compliance is a problem. I think it's a global problem. There's a difference between maybe one continent and the other, one country and the other, but there are legislative frameworks from licensing, registration, from quality management systems. But the issue is how now we are here in this year's summit to advocate the practices. Yesterday at the POLAD, we had a forum on how now these guidelines. The issue is not guidelines. The issue is not the information that we know that will influence compliance. The issue is why are not changing, practicing that possible behavior on the adhering to the recommended or the knowledge that we have. So it's an issue that really, let me admit, is not a problem. It's a challenge like it is in Uganda. Not just me to what extent. I need to do a documentation research probably, but it's a challenge. But what we are doing from time to time, we have the quality management systems, but also supporting supervisions, and normally we engage the private hospitals advisory board, but the regions, the regional health management team and the countries have this role, making supervision and looking at the quality of the services, and the adherence to the quality, safety of the services. Both. And we are saying this will be both. Not only the private, should not point fingers alone to the private facility. Are we comfortable that the quality, if you compare the quality of certain X dispensary and the dispensary that is owned by the private? Are there no quality issues, compliance that we also have to work on the government health facility? To finish with is what we are saying about public employed practitioners going to work in the private. It's not a prohibition, but we should not malpractice. We should not abuse the government regulations. Sometimes you find a carry license on duty just because there is financial gain. He reaches the clients on the government health facilities. Then goes to, I don't say the private health facility, the facility that he or she knows for his own interest. Thank you very much.
Thank you so much. If there are any questions, I think I have a minute. One. I'll take one. Go straight to the question because when
Thank you. My question goes direct to the environment. As we have learned, affairs out there is saving around 260,000 prior to NRT. Do you think is the right way now to engage private community farmers in NRT dispensing? Are we ready for that at the government?
My response is very short. When the policy is finalized, it will be disseminated. But there are a lot of pilot studies going on. But for the time being, we will communicate, and when the policy comes out with that evidence, I think it will explain it very clearly. But with the pilot findings, I hope this will happen soon. And the Ministry of Health, in collaboration with the agencies or the department that and Ministry of Health, will provide that policy statement. Thank you very much.
Thank you so much, my presenters, for well narrated and designs what has been done in the collaboration of government and private enhancing HIV services delivered across our country. Maybe USAID, if you ever worked from USAID before we went.
Distinguished panelists and ladies and gents, my name is Godfrey Nyobi. I'm the head of health system strengthening in USA. On behalf of USAID and managers of Afia Yambu and Kizazodari, we'd like to thank you all for having a great panel. Thanks for the great panelists here and the comments that have been raised. And I think as we have heard both from practitioners and the government and private sector, that together we believe the healthcare system is built by both sectors, both public and private. I think one of the comment that was raised here is like perhaps we have to agree that we cannot exist, one cannot exist over the other. We all need each other to make sure that the services that we're targeting to each individual Tanzania, we get them to the quality that is expected. So we believe working beyond private sector, beyond profit, private sector for profit, we believe working with foundations, but also on non-profit faith-based facilities and so forth. And we naturally, as practitioners, are normally inclined to the public sector. So I think most of us maybe here have experienced mostly the life of the public sector. But I think this is the opportunity for us to learn and be good advocate for the private sector beyond the profit and beyond financing or getting money from the private sector. We believe private sector is not only a sector by itself, but it's also a practice. A practice that the government can deploy some private sector modalities or private sector practices. In some government facilities or public facilities, they have already modeled like different practices that are private oriented, like businesses, the way they run the businesses, the way they segment the markets, like the clients who can pay more gets different part of service, or the leverage of those who cannot pay more. So I believe all of us can practice private sector in a way that we can. We believe that we can learn from the way the private sector is doing things. As we're looking into sustainability, we really have to look into like the business mindset in us. Like how can we deliver the healthcare services in the business mindset that allows us to be more effective, more efficient, and yet deliver high quality of service. Because that's the mentality of the private sector. It's quality of products, end of the day, it's the quality of service. So we can learn from that mentality. That's how we can be efficient and effective but also we can deliver the big quality. I think also we should leverage on collaboration more than competition, because I think end of the day, if we have to compete, maybe we should compete on compliance and compete on quality of care. So that would be, I think, a good way to improve the quality of services, because facilities are competing among each other, both public-private or public-public or private-private, around areas that are going to improve